as you know, I'm Dr. Keela Nichols. I'm a chiropractor. I've been practicing since 1989, so however many years that is. And my son, Dr. Jesse Nichols, is practicing with me now. And so I'm not going to tell you any more about me. You can just go to my website if you want to know more about us and our philosophy and our practice. And so that it's drkeeladc.com. All right, so one of the first things I want to teach you about is the difference between what I do and CranioSacral technique. They're both excellent cranial techniques. And I had a choice, do I want to just practice CranioSacral therapy, it's just a therapy, or do I want to practice Sacro-Occipital technique cranial therapy? And so I chose SOT, cranial therapy, because of, first of all, SOT is cranial technique is taught only to doctors, and the training is a lot more in-depth. We're dissecting skulls and the dura and the sutures and looking to see that, yes, there is tissue that goes between the sutures, so they cannot actually fuse and grow together, things like that. So, and it just takes years and a lot more money to learn. And this is why most chiropractors do not use SOT, infant cranial technique, because you have to, it's all postgraduate. In fact, infant technique is not even taught in chiropractic college. It's something that you have to have training after you graduate. So you have to pay for more training. You know how expensive those postgraduate classes are, more time. You know, it slows down your practice. You can't have a busy wreck 'em and crack 'em practice with babies. We know that because you try to stay on time and they throw up all over or something, or, you know, have a blowout and it gets everywhere. So a lot of chiropractors, very few chiropractors actually end up doing this. And it's very specific. I can tell, you know, if I move that temporal bone into external rotation and the child does poorly with it, I can put it back. So, and instead of where craniosacral therapy is an excellent technique, it is really taught to anyone who wants to pay for their seminars. You know, you can say, I've been a janitor all my life, I just want to do something different, and you hang out your shingle as a craniosacral therapist. So you have to be very discerning and make sure the person that you're using is really well trained in this and has an affinity for a real touch for it. And also in craniosacral therapy, one of the foundations of it is reaching this still point, and I won't go into the details of it except that it takes a real sensitive touch, and in adults it's not, you know, with training and experience you can get to that place, but in wiggly babies that are crying and kicking, you know, it really is very difficult to do that, and the baby can't tell you, you know, I have a headache after this. So you just want to make sure you're doing what you know really well. And you know, I've seen craniosacral therapists do a great job, and I've also seen them work on babies, and I'm thinking there is no way that you can feel that still point with that baby wiggling all over the place and screaming. And so anyway, that's why I chose to use Sacro-Occipital technique. SOT is a technique, a chiropractic technique that a few chiropractors use. It's a big umbrella of a technique. Underneath it are many things. Cranial is just one component, and infant cranial is even a smaller component. Now, I was asked if I know anyone. Hey, sweetheart, it's good to see you. I was asked to see if I could find someone in the Fort Worth area that does this. Really, the question is there someone in Texas that does this? Because there are so few chiropractors that use this technique. So probably there are half a dozen in the state of Texas, and most states don't have anyone that actually uses this technique. And again, let me remind you, and I'm not trying to steal patients from other people. You know I'm busy. I'm not trying to build a practice, but I just know that babies can't tell you, I felt bad after this. I've had a headache ever since this has happened. So you just want someone that really knows what they're doing, is really gentle and good at what they're doing. But so I don't know where I was going with that, except that.
So you're not so Fort Worth.
Oh, yeah. anyway, so there's it. Next slide. Okay. Oh, this is what I really, really want to share with you. What's the difference between what I do and just putting them in a dot band, or what are they, the star band? I don't think they're around here anymore. Well, one of my favorite topics. Let's see, where do I start? Okay. So what I seek to do, well, let me back up. So say you have a child whose right occiput is really flat, okay? But the rest of his head is nice and round, okay? So I get a lot of these babies. You guys have sent me babies like this a lot. And so what's happening is that lambdoid suture on this baby has been jammed. And when, for whatever reason, it's not freely opening and growing as the other sutures are. So when the baby was first born, everything looked pretty good sometimes, and sometimes you can see it from the beginning, but more often they look pretty good right when they're, fresh. And as they grow, the rest of the head is growing and expanding while that area has a deficit. It can't keep up because that suture is jammed. And so what these cranial helmets, cranial bands do is they restrict the growing side so that it can match the side of deficit. Instead of what I do is I open up the sutures and loosen them up so that through each growth spurt, the baby can start to catch up and that side of deficit can start to catch up. Does that make sense to you? Okay, so as we know, what causes cranial expansion as a baby's growing? What is stimulating that cranial expansion? The brain growth. So if you're inhibiting expansion on the normal side, I have to wonder, how's that affecting the brain growth? I mean, I would love to do studies, MRIs of the brains of these children going through these different therapies, different stages of their growth. But there's no money in that, so I guess it's not going to happen. But that's what I do. I want normal function. You guys are working on these littles. You don't ever want to cause harm. Who can sleep at night if you're doing something that might harm these babies? So anyway, that's the difference in approach. I'm releasing restrictions on the side of deficit, and what they're doing is restricting growth on the healthy side. And I will just point out, do you know what the training is for these orthotists that decide what helmets to put on these babies? It's 2 weeks. Oh, no. So I feel like I have a little more experience to bring to the table on that. Okay, so I was just reading about their employees' evaluation of working there and everything. Anyway, I won't go there. Okay, so I don't know. There's good people in every field. It's just really what are you looking for? What are you trying to accomplish? Yeah. So there's that. That's just a very superficial explanation, but you guys can probably expand in your thinking other possibilities with that. And so this is another reason that when you send babies in, their heads, that occipital bone's not going to pop back out. So we loosen and direct, and then wait for the growth spurt. And with each growth spurt, we want to see that staying loose. And so after the growth spurt, we check it. Is it loose? Did it hit a restriction again? We keep it loose. So I really get a lot of work done between the growth spurts and wait for the growth spurts to help push it out. Okay, next slide. You guys please pop in if you have comments or questions, okay? So I don't know if you know this brilliant man, Dr. Fioron, at the Craniofacial Center of Dallas, but he does cranial surgeries on infants for, abnormalities, cleft palates, and cranial suture fusions, and, Synostoses and things like that. And he's got a fabulous website. I encourage you guys to go and read all through it. It's very, very educational. And this is a comment he has on his website. At our center in Dallas, we have concerns about restricting skull growth. I've never talked to him about what I do. We've seen some of the same patients, but I've never had a conversation with him and told him my opinion of restricting skull growth. But he's aware of it, apparently. And based on those studies showing no benefits to using helmets, excuse me, we now almost never recommend using these constricting devices in any children. Okay, excuse my ragweed invasion. Those that have taken my homeopathy class, you know what to take. Okay. Okay, next slide. All right, so what's the difference between synostosis and deformational plagiocephaly? And I'm just picking plagiocephaly because that's really the parallelogram position, but we know there are different kinds. They're not all the parallelogram, but I'm just going to use that as kind of a general general explanation or general term. That's what I'm trying to say. A synostosis is when the cranial bones have really, these two bones, like this parietal and occipital bone, have been, as the child developed, there was no suture there. There was no suture. It didn't grow. And so it's really one bone instead of two bones. And it can be any suture. You know, it can be the sagittal suture, coronal suture. It can be any suture. And those bones were never two bones. They grew as one bone. That's a true synostosis. Okay, I can't make a suture. I know how to evaluate all these babies you send me, the babies I get. I evaluate, do I think there's a true synostosis there? Because if there is, that goes to Dr. Fearon or whoever they choose to go to. He's just fabulous. But now, another thing that they will call a synostosis is when the sutures are so jammed together that they cannot move. And it's not that, there's membrane between those sutures. So the bones cannot invade that membrane and actually grow together and fuse. That doesn't really happen. Even in adults, it doesn't fuse. But they can grow so close together and get so tight that it's hard to find movement in there anymore. And so that's another time that they will do surgeries. And they'll create a bigger suture in there. But I've had babies that have been to Dr. Fearon, and I don't know how he feels about this, but they were going to do surgery on him, and I'm like, I can feel the suture here, and I can feel movement here. And so the parents chose to avoid the surgery, and these children have turned out fine because it was just so tight, it probably would have not grown. But I just work, and I get in there, and I dig in there, and I move and reposition and release the dural tension on that bone. And I've had some just exciting results in babies that were scheduled for this surgery, and we've avoided. So but a true synostosis where there is no suture there does require surgery. Now, I have had some where you can see a suture on a CT, but part of the suture was truly synostosed and part wasn't. So it's a tricky business, but there are certain ways, like you can see these two kinds of plagiocephaly. So the things you look for, like this one on the left, when they're positioned this way, both sides are small on the same side, we know that's true synostosis. But if they're positioned the way on the right, we know that's called a deformation. It's a deformed head, and they say it's from lying on one side. I'm not sure about that. Otherwise, I think we'd all have square heads. But okay, back to the synostosis. Fused sutures, we talked about that. Generally, a cranial problem is going to show up between 2 and 4 months. Sometimes it's really obvious from the beginning. But these babies that start out really nice, but they have restriction as they grow and they hit the restriction, that starts to show up between 2 and 4 months often. Okay, so the one on the right, I treat. The one on the left, he treats. Alrighty, Dr. Jesse, next. All right, tricked you. So what is my treatment plan? Okay, my objectives. One of them is to decrease dural torque. One of the first things I do with a baby is I tell the mom, just relax and watch this, it's going to be okay. But I get them by their calves and I swing them upside down real close to their Achilles tendon. I'm trying to kind of rock and stretch that Achilles tendon. I want to see if they hang straight. All right? If they arch back, that tells me there is tension and tightness in the dura somewhere that's pulling them, arching back. If they're twisting, in the mid-thoracics, that's where that dural torque, it's like a twist in the spinal sleeve, okay? If it's their neck is turned to the right or left or whatever, that tells me that's where the dural tension is, okay? If they're arched back, it's all cranial. So there are a little bit more to that, but that gives you a good understanding if they're like, you tell them, now she's going to swing your child upside down. It's going to be okay. The child's been upside down for months. It's okay. It's familiar with that. And most children like it. Of course, we always evaluate for any hip dysplasia or problems like that. If the baby blanches, we stop immediately. There's some circulation problem. And so, but I give parents this as homework to do at home to keep releasing that dural torque. I have adults, I think, if only we could just swing you upside down without ruining your ankles and your knees and hips, because they have this dural tension. So just the weight of their body starts to pull that dural torque out. And then if it's just a cranial issue, sometimes it's a sacral issue, then that's my job. That's where I have to come in. So you can imagine if the dura, the dura attaches at the sacrum, foramen magnum, C2, in certain places in the head, then if that is tight in one area, it's going to pull from the inside. So I have to evaluate, is this just a sutural restriction, or is the dura pulling it from the inside, holding that occipital bone in, whatever the problem is. So that's my job, to release that dural tension. These babies that have the real flat A to P head, so their fox is really tight, right? When they're real narrow this way, their tentorum is really tight. So that's my job, is to manipulate that dura so that it will allow that area to grow and expand. Okay. And of course, I talked about releasing sutures that are restricted. These can be in the cranial vault. They can be the zygomas. They can be in the palate. A lot of restrictions in the mouth affect their ability to nurse and their masseter and pterygoid muscles to function normally. If it's really tight, it's hard for those muscles to be loose. Their tongue thrust, all those things. If their palate's really narrow because their maxilla has restriction in the intermaxillary suture, their palate can be really high and they can't get a good suction on the nipple, right? If they're really narrow A to P, then they're going to gag real easy, and that nipple is going to gag. If the mom has a large nipple, it's going to go too far back and cause problems. So I work a lot in their mouths, and so...
Would you say that
yes.
that sometimes can be done instead of tongue tie release, lip tie?
Yeah, well, if we do therapy to loosen those, they're just soft tissues. If we can grab a hold of them and loosen those tissues and stretch them, yeah, absolutely. It depends on how crucial it is. These babies, they have to be nourished. And if they're just not thriving, well, you could probably speak on this. If they're just not thriving, sometimes there's not time. You just got to move on so they can start getting their nourishment. Yeah. But if it's a minor issue, and they're doing okay, you're the one that should be up here explaining this. Talk to her about it too.
I usually suggest doing body work like Cranial or free work type of CranioSacral, much better.
Yeah.
Before just deciding to do any type of revision.
Yeah.
A lot of times with body work that could really help promote better function and mobility of the mouth on its own without needing that revision.
Right, because it may not just be a mouth problem. Yeah, because we want the whole global function to be improved. Yeah. So yeah, it's kind of a call, depending on the situation. But it can, yes, it can. You can do it without the releases. Another thing is, my objective is to encourage normal expansion and positioning. So once we got the sutures released, we want to start kind of like orthodontics. We want to start showing that bone which way it's supposed to go. this is the direction we're trying to go, or whatever. And that takes a little while. And a lot of it, we're just waiting on those growth spurts. We get as much done as we can, waiting on that growth spurt, that expansion from within to push out. It's really exciting, really fun. Another thing, we're going to balance CSF circulation. So back to the flat right occiput. You can imagine if you saw an MRI in the side of that brain, there's going to be less circulation in that area of CSF because the meninges is going to be a little closer into the brain. I mean, wouldn't you just love to see MRIs of these kids' brains? I wish so much. But anyway, so that's the other thing I have to do is make sure the CSF circulation is healthy. And back to the tentorium and the falx tension, I really feel like some of these cranial conditions, especially when there's tension in those membranes, contribute to these Chiari formations. And then the Chiaris contribute to the syrinx or the syringomyelias. And I have adults with that, and I just wish I could have treated them as infants. But it's interesting to see them now and think, I bet I know what your head was like as an infant. So it's a privilege to get to work on them when they're fresh and new and not have to have them suffer as they're adults. So the balance of CSF circulation, this is one thing that CranioSacral therapy really is great at, and of course, my treatments do as well, is make sure the CSF is moving equally throughout all the sutures, throughout all the sinuses and the ventricles and up and down the spine and the sacrum and back up. And we started without you. Do you want me to start over?
Yes, please.
Okay. Have a seat, but not in front of the... There you go.
You're in the middle of a camera.
Underneath that, it says spinal and extremity manipulation if needed. Now, those of you who've been to a chiropractor, surely you know we are not cracking their joints. Okay, that's adults. We don't do that to little ones. They're not fully ossified and in the vertebra, and their ligaments are so tender. It's just really, truly manipulating. We're just kind of like, it's like if you have a boat stuck in a groove. You just kind of have to shimmy it with, So that wasn't a good example, but think of your own better example. We're just trying to shimmy it and loosen it and guide it and help it to go where it's supposed to be. The body wants to be whole and complete. We just have to remove the restrictions that are keeping it from accomplishing its goal. Now, I had a baby. We do extremity manipulations as well. I had a baby who I was treating cranially, and he would always hold his arm in. But babies, they do different things. I didn't think anything about it until the third visit. I noticed this one was moving around. This one he would still kind of keep in close to him. And so she said, yeah, he always does that. And so I checked his elbow, and he had a radial head misalignment. And I just moved it, and it just clicked back into place, and he just went like a butterfly coming out of a chrysalis. So I always check elbows, wrists, arms, legs, shoulders, hips, everything now from after that. It just takes 5 more minutes. Okay, and of course we check their spine to make sure that it's freely moving and hips, all those things. Sacral issues are real common with cranial issues. Okay, now, so when you send your babies to me, what am I going to recommend for them? Generally, I have them come weekly or bi-weekly. If it's moderate to severe, it'll be weekly. If it's moderate, it'll be not bi-weekly, bi-monthly, like weekly or every 2 weeks, and until their 3-month growth spurt, because I want to get as much done as I can before that expansion, opportunity. And then once after that, I may reduce their frequency, or I may keep them coming until the 6-month growth spurt, because I really want to get it in before that expansion opportunity. 9 months is the next big goal that we're looking towards, and so it just depends on the severity of it. And then we reassess and we decrease frequency as improvement is noted. The cost is for the first visit is 100 to 175. After that, it's 87, although I'm about to go up to the big 92 at the end of the year. Okie dokie. Great. Okay, next slide. The importance of cranial treatment. Of course, nursing issues, right? Vagus nerve entrapment. 9 of the 12 cranial nerves come out through somewhere attached to the sphenoid bone. The other 3 come out at the mastoid suture, so you can imagine that would be really important to have plenty of room in for the cranial nerves to exit, especially vagus nerve. We all know the problems that can cause. Musculoskeletal alignment and development. If their head is tipped, their first vertebra is going to be tipped, their spine, their cervical is going to be tipped, and there we have a scoliosis developing in a descending pattern. The brain increases 240% in the first year. 80 to 90% of gray and white matter forms in the first year. We want plenty of room for expansion, plenty of CSF circulation to bring out the toxins, plenty of circulation coming in to these little ones. The majority of the nervous system is formed by 6 years old, so we have this really precious window to take care of this. Okay, next slide. Cesarean births can produce a beautiful baby head, not always though, that can later present with crowding of the sinuses and the oral sutures. When the baby comes through the vaginal canal, cranial bones collapse, right? As the baby comes out, cranial bones expand, they take their first breath, that starts normal cranial motion. Each cranial bone has a direction it moves when you breathe in, when you breathe out. So cesarean babies are robbed of this. Although it can save lives, sometimes it's necessary, like a placenta previa complete or something like that. But we want to provide what they missed out in the vaginal delivery by loosening those cranial sutures so they can grow and expand, right? Cranial C-section babies have really tight heads. Okay, next. And other annoyances, like this adorable little nerdy boy on the right, his glasses are just not going to sit straight. That can be just really annoying. This girl on the left, her TMJ is going to bother her. It's going to be painful to her. Okay, next. And other than aesthetics, what's the problem? Well, look at all these foramina in the skull that these cranial nerves have to get through. And you can imagine if you have a plagiocephaly or some kind of deformity there that those foramina are going to be crowded and the cranial nerves are going to be crowded. And I saw this recently in a patient of mine who's an adult who has quite a scoliosis. And she got shingles, which can easily go away with homeopathy, but it was taking her forever. And I think it's because her foramina were really crowded and that facial nerve was not getting, is having trouble for the inflammation to go down and to heal and get the circulation it needed because of her cranial malposition and her the foramina being crowded. So
she's one of those patients that you really wish you could have gotten your hands on as an infant, because even just looking at her, you see the cranial, her head is always off this way and her head is plagiocephalic.
Yeah. How her life could have changed.
Even in her 70s.
Yeah. How it would have changed her whole life. And then osteoporosis with all these problems. So with scoliosis, it's a sad thing. Okay, next slide. Okay, here's some quick case studies. I'm terrible at taking pictures. I need to get better at it. That's one thing Cranial Technologies has encouraged me. I'm like, how do they get those good pictures? But anyway, this child has a true deformational plagiocephaly, no synostosis. You see the forehead on the right is anterior, the zygoma is anterior, the back of the right side of his head is really flat. Next slide. Here he is as a cute little 13-year-old boy. He's got quite a cowlick, but his frontal is level, his occiput is level, his zygomas are level. Okay, next. This one was 35 years ago. This little baby, his eye would not open, and so they were going to surgically do some changes to the eyelid to make it open. And the problem was not the soft tissue. The problem was the orbit, right? The orbit was small and it was recessed. So the parents agreed to let me do cranial on him. So I got to work on him till he was about 6 months, and I never got to see the result because I'm waiting on growth and expansion to really see the full result. So they moved off at 6 months, and they sent me this picture of him when he was 4 years old, and he looks beautiful. Although I wish I could have fixed that head tilt, but I didn't get him long enough to. Anyway. Okay, next one. Okay, this is one of my favorite cases. So how are we doing on time? Oh, okay. So I wish I had the foresight to take better pictures. But this woman carried twins to 42 weeks. She is a warrior mama. I'm telling you. So the one on the bottom was totally smashed. He came out, his nose was laying on sideways on his face. He had a terrible torticollis. His one side of his face was really recessed and small. His jaw was way off. He couldn't hardly nurse because his jaw was so malpositioned. He was not thriving. And the second one, the train had been through, and he came out big and bright and beautiful and symmetrical, right? Imagine these boys going through life as twins, the handsome brother, and the other one, with the glasses crooked, his jaw, and braces, and anyway, so I worked on them for about 6 months. Next slide. And the beautiful one, we started seeing, he didn't look as good as the one that had the problems. So we started seeing some asymmetry in his forehead and his eyes, and so as he grew, so we did a little work on him. And then after about 9 months, they moved off. And here, go ahead, and here he is as an adult. And just praise God, what a difference that made in this child's future. Self-esteem, all those things. So those are my the case studies I brought today. Next slide. Oh, something you need to know. My clinic is the front of my home. I had the big fancy clinic for years. It was such a headache. Dr. Nadeau, I don't know if you ever get headaches, but you could probably relate to what I'm saying. And so I'm just like, actually, the Lord told me to go home, raise my kids. So I had a clinic in my home for the Klingons, and then I just stayed in my home. And it was a much better situation. Children were comfortable, homeschool families, they spend the whole morning, get everybody adjusted, play with my kid, so it's just the direction I ended up going. So patients will call and I got the address, but I'm in a residential area, but this is the place. So they're going to be coming to my home. The front of my home is a waiting room and a treatment room. And it's a sweet place. We got toys all over the place. They go in the living room, play with my grandkids' toys, and so it's a real comfy place. There's room for, it's a home. If moms need to stay and change their baby or nurse or feed or whatever, you put their kids down with their Chick-fil-A at the kitchen table, whatever. So, and my assistants are fabulous working with kids when we treat the mamas. My assistants love the opportunity to hold those babies. Laura can balance 2 on her lap and do her work at the same time. She's just amazing. But we love having them. So we're very child friendly, of course, as you guys are. Okay, next. I brought some brochures. I don't know if you want hard copies. I sent Christine a PDF that looks like this. It's purple on the front, and it says the same thing as my hard copies say. And it's a great educational material for your patients. I have trouble making things short, so it's long. But be sure you guys read this, because I don't want your patients coming in knowing more about this than you do, okay? So they're here. I also brought some homeopathy brochures. If you guys want to know, one's about the rules of homeopathy. I just want you to stay ahead of your patients. One's about just what is homeopathy, and one's about how do you decide when to take the next dose, in acute conditions. So you guys help yourself with that. Water treatments sometimes they're very loud, as you know. We finally invested in those little foam earplugs, because sometimes babies, they want to be the boss of their body, and they don't want to, but it does not hurt. I've had babies fall asleep through it, which I love working with babies when they're sleeping, don't we all? Because you can get so much more done. But I want to show you guys what it feels like and what it looks like. That's why this table is here, so you can kind of get a sense. I want you to know that it does not hurt. Okay, next slide. Okay, you just leave that up. I finally have a website after 40 years. So, and my contact information, or you can just go to drkeeladc.com. So, let me just have anybody coming over here, and I want to show you cranial motion.